how to improve outcome of patients with myelodysplastic syndromes when we think about this transplantation issue is a big challenge. If we think about the pre-transplant part of the problem, the first thing is to see what is disease-related and patient-related. For patients with high-risk disease, as I previously mentioned, we need to consider transplant for almost anybody, so it's pretty easy for this choice. How to reach transplantation or to bridge transplantation, you have mainly two options: hypomethylating agents and induction chemotherapy. The choice of induction therapy versus hypomethylating agent, for the moment we don't have any strong evidence going from one or the other. We may think that cytogenetics may be something important, and for example, if you have bad cytogenetics for MDS patient, maybe hypomethylating agents will give you more results than the induction chemotherapy. But if you look at the rates of complete remission, that's one of the key issues to allow patients to undergo transplantation. Maybe induction chemotherapy is more prompt, give you more remission and marrow remission. So basically, according to the age of the patient, to the cytogenetics, we may decide which is the best for a patient. And obviously, an important point is what the patient is okay or not to go to. Because induction chemotherapy means hospitalization, potentially some morbidity and mortality, and but it's faster than hypomethylating agent therapy. So it's a question of choice and discussion, a lot of discussion with the patient to choose what's the good thing for a specific patient. Regarding the second part of the question, how we can optimize the outcome of patients with myelodysplastic syndrome and transplantation, there's a question about the conditioning regimen. There's some advance recently in the type of conditioning regimen that we can use, and basically the paradigm that we have some time ago we have only myeloablative conditioning and reduced intensity transplantation is shifting a little bit. Patients with myelodysplastic syndromes are usually older adults, and the use of myeloablative conditioning is more complicated for patients if we want to have a broad population of patients that can have access to allogeneic transplantation. So currently, myeloablative conditioning is only a minority of cases. The majority of cases are treated with reduced intensity conditioning. This reduced intensity conditioning allows a larger population to have access, but are associated with maybe slight increase in relapse rate, because you don't have the myeloablative effect that you have with the older conditioning. Currently, there are some other options that are developed. The use of reduced toxicity conditioning is something that is in between the reduced intensity conditioning and the myeloablative one. This is one of the options. The other thing is the use of alternative donors, especially haploidentical transplantation. That also is a way for us to get access to transplantation for a larger population of patients with myelodysplastic syndromes. Is there a single answer in this case? I don't think so. Clearly, the take-home message is consider any kind of transplantation from the beginning for patients with myelodysplastic syndromes, even if for patients with low-risk disease, you know that you may not have to transplant in the next years, but consider it from the beginning. The last part that we need to talk about when we think about transplant outcome and myelodysplastic syndromes is how we can try to prevent relapse after transplantation. There's some interesting work going on with the use of preemptive treatment after transplantation with different kind of compounds. The one that has been the most used are hypomethylating agents. And clearly that's something that may have an impact, especially in the group of patients with the highest risk of relapse. Bad cytogenetics, high-risk disease, that's maybe the group of patients that may have a benefit from the use of hypomethylating agent after transplantation. There are some studies also with other agents like IMiDs, lenalidomide, for example, but it's not completely sure that the toxicity of this agent after transplantation is good, so we really need to put it on the side for the moment. There's other compounds that are currently developed, other kind of approaches that can be sought, done only from infusions, maybe some vaccination with WT1, for example, things like that can be sought for this patient, especially the one with the highest risk of disease. But for the moment, we don't have any real straightforward answer. But clearly, for this patient, especially after the first 2 months or 3 months, we need to consider preemptive treatment, potentially with hypomethylating agent in the big group of patients with a higher risk of relapse.